Hello, this is JP Haas, MSK, and I am going to do MSK MRI 101 for the ankle. This is a starting point module or basic foundational thing to try to get comfortable reading ankle MRI when you first get to the bone reading room. It has protocols, reading patterns, and reporting with multiple normal images. And the idea and the goal of this is to be a fairly quick run through of ankle MRI to get a starting point and a strategy for reading these when you first get to the bone room and to be more comfortable with that. So with that, we'll just go forward. The outline is we'll do MRI ankle protocols and uses. We'll talk very quickly about reporting, freehand versus template. We'll do a pattern-based reading approach. So just like all the rest of the joints, I have a pattern-based document that I have on Word that I will give you access to that you can use as just a checklist approach to just go down each structure and look at each one, and then you can not miss anything and just have a very uniform approach to how you read MRIs, which I find very good and helpful, especially when you're beginning. The goal is just to give you a high yield basic approach to reading cases and to be more comfortable reading ankle MRI. There are scrollable, normalish images throughout this, and then at the end I put all the images together, which if you do use this PowerPoint at a later date, you'd be able to just scroll on those images and to kind of go over the anatomy yourself. This is the routine ankle protocol. It has 6 sequences, which is 3 planes, T1 and PD fat sat, with the 2 coronal images being slightly different in alignment. This is the main workhorse protocol which we use, and I'll talk about why that coronal oblique T2 is good, but I have a plane there that's showing you what it is. It's sort of along this axis of the talus, and there are certain structures that you can see well in this plane that you don't see as well in other planes. This is also an example of a sequence that is I think fairly unique to UNMC. I don't remember it from my training, so just know that it's a good sequence that we're definitely used to seeing here, but if you go out to other places after you leave, it might not be there unless you put it in. This I'm just going to put in for reference because it's a busy slide that I don't think we need to get into much just to lose focus too much, but we do have a mid forefoot protocol, which is just basically to look at a different location. We have an osteomyelitis protocol, which emphasizes stir-weighted imaging and post-contrast imaging to look for osteomyelitis. And then we have an osteomyelitis without contrast. So we're going to mostly focus on the normal anatomy and all these ligaments and tendons and bones that we want to learn about for this, and not talk specifically as much about osteomyelitis, which is a common thing that we look for. So just a little bit of a different scope of topic. Okay, so laying out thinking about how you lay out the study is a really good start to how to read MRI of any joint. But there's no right way to do this, but I would encourage you just to think about how you do it and make a strategy and decide how you like to look at it, and then do it the same every single time. So for instance, when I hang a study, I tend to just put the sagittals across the top, the axials across the bottom, and then I have my coronal at the top right, and then I have this oblique sequence that I was talking about in the bottom right. There's no right way to do that, but that's how I like to look at it, and it just makes things very consistent and I think helpful when you read cases. Here's the reading pattern document for ankle. It basically is tendons and ligaments, and then a couple other loose topics at the end. So we'll go through these one by one. I just clipped these different areas. So we'll look at the Achilles and the tendons, peroneal tendons, medial tendons, and I'll clip that and put it at the bottom right hand of the screen, and then we'll just go through what each one looks like with normal imaging and discussion. So hopefully if you have this document and you're going through this module, and then later you're looking at an ankle MRI, you'll be able to just go right down the list and be able to look at cases. Here's a template from RSNA RAD report of ankle reporting. We don't use this or anything else like this right now because we use free dictation at this time. The other ones that I've shown so far for knee and shoulder, I've liked the template reporting. This would be an example of one that I don't like just because it's too much. I think it would be a huge setup for template error just to every single time to make sure you have everything that's normal is normal and everything that's not normal is discussed. So, I don't think this one is as helpful, but if you just want to look through this as a reference to look at all these different anatomic structures that we're going to be thinking about in the ankle MRI, that's fine. But this is really just there as mostly as an example of a template report I did not like as much. We did come together as a MSK group and make some templates, not for every joint, but for some joints that you can find under Dr. Peters, who led that effort. And he does have one for ankle, which is nice, much more short and concise than that template report we just had before. But this would be a great start for a template of normal MRI reporting if you'd like to use it. Okay, so now we talked about how to hang it. Now we talk about how we look at it. You can definitely decide how you want to look at it as on your own, but as long as you do it consistently, that would be my advice. And so I'll just take you through how I do it. So broadly, my approach is I just start at the Achilles, then I turn around the corner of the heel and look at the plantar fascia. Then I look at all the tendons. There's three basic groups of tendons to look at. We have the lateral tendons, the medial tendons, and the anterior tendons. Then so that's kind of the outside in, doing all the tendons first. Then I'll go up high to the very superior portion of the study and look at the syndesmotic ligaments, which will be the anterior and posterior inferior tibiofibular ligaments, and then I'll follow those down to the remainder of the lateral ligaments. Once I'm done with the lateral ligaments, I'll jump to the medial ankle and look at the medial ligaments, with the main ones to be concerning about the deltoid and spring ligament. After I'm done with all the ligaments, then I'll do talar dome. Then I'll look at the cartilage of the ankle, and I'll do a look at all the other joints of the ankle. I'll look at sinus tarsi, and one more look through the bones and marrow. So that's basically the quick and dirty of how I do it, and we'll go through that. Structure by structure. So here's Achilles tendon. The normal morphology is concave, anterior, contour, and axial. So, it shouldn't be thick. You should always have kind of a gentle concavity to this, to the Achilles tendon as you scroll through it. I look at it on axial and sagittal, looking for Achilles tendinosis, so that'll be thickening and increased T2 signal. If you have any kind of fluid or disruption, you can start to get into talk about partial tears. There's different areas that these tear depending on sort of clinical scenario. So the weekend warriors doing work, middle-aged guys or whoever, tend to get the critical zone tear, so that'll be a little bit more of a superior tear. If you have high-level athletes, that would be who could potentially get the more insertional tear, just as a kind of general rule. Okay, so let's look at Achilles tendon. Here's a normal-ish ankle. We're going to follow it on sagittal and just find the Achilles tendon, nice dark black structure, inserting on the posterior calcaneus. That's normal. This is called the retrocalcanea bursa. It's just a small fluid thing. If it's distended with fluid or too much fluid, that can be called bursitis, but that's just a normal structure to know. That's a little bit, tiny bit more than usual. I don't know, maybe it could be called tiny retrocalcaneal bursitis, but and then on axial would be other plane to look, and just once again, just to show this normal Achilles. This is going from low to high. Nothing really worrisome here. Next topic is the plantar fascia, which is the fibrous aponeurosis and arch support. It originates from the medial process of the calcaneal tuberosity, which is just what the name for the insertion is on the calcaneus. It's best evaluated in the primarily the coronal and sagittal planes, and it divides into three parts named for just what muscles it's adjacent to. So it has a central cord, a lateral aponeurosis, and a medial aponeurosis. And the central cord is the largest, and it's just named for its adjacent muscle. So this is the red one here, right here. And it's this dark, the plantar fascia itself is this dark superficial structure, but just adjacent to this is the muscle. So that's the flexor digitorum brevis muscle. And then the other smaller parts are named for the muscles that are right next to them. So this is more lateral. This is the abductor digiti minimi, and this is the abductor hallucis. And you can just follow those out on coronal and just see how they attach at the calcaneus. The other one is the sagittal, and you just want to find this nice dark thin band, which is at the plantar surface of the foot, inserting on the inferior calcaneus. All right, so let's look at that on images. Start with the sagittal images, and you see nice dark thin plantar fascia inserting where it's supposed to. Nothing is too thick. Looks normal. And here's our coronal, so we're going to follow this out. Now, we already talked about the different chords or bands, and we're getting towards where they are all kind of coming together. But we know this is flexor digitorum brevis. We know that's abductor digiti minimi, and that's flexor hallucis. But as it comes across, you just can talk about, this is the medial aponeurosis, this is the lateral aponeurosis, this is that central larger chord, all normal. Okay, so that's plantar fascia. Next topic is peroneus longus and brevis. So I just usually start at the lateral ankle. The main tendons to know at the lateral ankle are peroneus longus and brevis. The one that tends to get impinged between the fibula and the peroneus longus tendon is peroneus brevis. So one of the main things we look at in the lateral ankle is the peroneus brevis to see if it's torn or has split tearing. Now it has something called the C sign, which is just where you have abnormal morphology and a C shape of the peroneus brevis between the two. And I think we have an example of that. The superficial structure that keeps everything in place here is the superior peroneal retinaculum. So we have a normal case here where we have a peroneus brevis, which is a little more deep, the peroneus longus, which is a little more superficial, and the fibular head here with that very thin structure, superficial, the superior peroneal retinaculum. Just adjacent to this, if you just keep going inferiorly, there's also an inferior peroneal retinaculum. I don't know if that's consistently seen because I just can't think that I've noticed it that very often or consistently, at least on ankle MRI. And here it is on schematic picture of those peroneal tendons coming through. So we can look at some images of that. Looks like these are coming from low to high. So we kind of have to, usually I like to go from high to low, so we have to keep that in mind. But here's the brevis, here's the longus, and we followed those through, and there was no abnormal morphology, there was no abnormal shape, so you just have to look at that. The medial tendons. The medial tendons is easily remembered as Tom, Dick, and Harry. So Tom is tibialis posterior, Dick is flexor digitorum longus, and Harry is flexor hallucis longus. The flexor hallucis longus is the one that can communicate with the ankle joint space as a normal variant. So if you have a little fluid around that tendon, it's fine. And the tibialis posterior is the most important tendon in arch support. The general rule is that the tibialis posterior can be at least up to 2 times the diameter of the adjacent flexor digitorum longus. But otherwise, if you're looking at thickening or increased T2 signal in the tibialis posterior, you're thinking about tendinosis. The other thing to at least probably keep in mind is also that the tibialis posterior, as you get to the ankle, as you get to its distal attachment, can have accessory ossicle in it. So if you have an accessory navicular bone, that's involving the tibialis posterior tendon. So sometimes that has to be kept in mind as well as you look at the ankle MRI. But here's our medial ankles here in yellow. The Tom, Dick, and Harry. I think the and is technically also the neurovascular bundle, which you can note as well. Here's some example of normal and abnormal tibialis posterior tendons. So this is a normal right here. This is an abnormal where it's too thick and it has fluid around it, so that's tendinosis and tenosynovitis. And here's a coronal image where you see the tibialis posterior tendon here, which is too thick, also has fluid around it. Now there's a associated finding here, and this is part of that deltoid ligament, which we'll get to more later, the superficial deltoid. But that makes a turn, and you can sometimes find this making the turn as to where it becomes the spring ligament. So not only is the tibialis posterior abnormal, but the spring ligament is abnormal right here. So those are 2 findings that can go together and lead to arch support problems or arch abnormalities. I look at the tendons and ligaments separate. So, I guess it's good if you could kind of look at it and start making your assessment together, I suppose, depending on how you like to do it. But if I was doing it, I'd be looking at this tibialis tendon, and then I'd be finishing up all my tendons, and then later I'd be coming back to this spring ligament and deltoid ligament to evaluate that separately. Even though in the impression, if you need to, you can talk about it in one concept. Okay, so we're going to look at Tom, Dick, and Harry. This is a axial T1 weighted image coming from low to high, which can be a little bit harder, but this is the tibialis. Tom, Dick, and Harry are going to start to come into focus over here somewhere, right here. Tom, Dick, hairy. So that's one run through of those medial tendons, and once again, it'll probably be very helpful to do to scroll it on your own just to get used to how those look. The anterior tendons is Tom, Harry, and Dick. So just a slightly different order: tibialis anterior, extensor hallucis longus, extensor digitorum, shown in the blue out front here. Now it's very unusual for these to be abnormal, but certainly it can happen. So you just take a quick look, knowing that it's Tom, Harry, and Dick. So let's see if we can not miss those here. Tom, Harry, Dick would be the order on the axial plane. Okay, so after I'm done with all the ligaments, we'll jump up to the syndesmotic ligaments. And this is the syndesmosis is the name for the articulation between the distal fibula and the distal tibia. And this is shown here on this image as the anterior syndesmosis and the posterior syndesmosis. And the name structures we're looking at here are the anterior inferior tibiofibular ligament and the posterior inferior tibiofibular ligament. Now this is high ankle sprain, so if you have an athlete with a high ankle sprain, this is what they're talking about. And I'd like to try to find these structures on one or two axial images as these nice linear hypointense structures that attach to the tibia and fibula like that. Between the two, there's an interosseous membrane, like right here. Which also kind of keeps things in place. And there's a fluid recess that you can look at on the coronal. So if you see some fluid in there, it's fine if it's up to 1 centimeters in length, around 1 centimeters in length. I don't think it's a firm rule. But if you have too much fluid there, or it's much longer than 1 centimeter, you can think about an interosseous membrane disruption of the tibiofibular syndesmosis. So here's a couple examples from radiology assistant down here. This is normal. Nice normal thin black, just like we're trying to see. Here's a grade 2. So this isn't fluid sensitive, but I mean, this is enough to say, oh, look, it's a little bit thick and consistent with grade 2 sprain, which would be technically abnormal edema about the ligament with a partial disruption of the ligament. And this is grade 3 injury. So you have to kind of see this further. It's indistinct, but it looks like they're concerned about a full thickness disruption of that anterior inferior tibiofibular ligament on that image. Okay, so this is, again, low to high, so we got to go up high to the syndesmosis. And what I'm looking for is starting here, maybe here. We're just getting to the ankle joint, so right here. Looking for this anterior inferior tibiofibular ligament here, which I'm just kind of trying to bracket to not obscure the ligament, and the posterior here. Now this is a little bit heterogeneous and hard to see, but this is how it should look. So finishing up, just scrolling through the rest of that. Okay, and then after we're done with the syndesmotic ligaments, we can continue more inferiorly into the lateral complex ligaments. There's 3 main ligaments to know in this location. It's the anterior talofibular ligament, the posterior talofibular ligament, and the calcaneofibular ligament. The anterior talofibular ligament is the one that we think about first and foremost, just because it's the most commonly injured. Because if you have an if you have an isolated ankle ligament sprain at the lateral ankle, it should be the anterior talofibular ligament. So here's a nice example of what normal should look like. The anterior talofibular ligament here should be a nice dark black band going from the distal fibula to the talus. And here's the posterior talofibular ligament, which can be a little bit more thick and striated as a normal variant, as in this case, that is the usual look for the posterior talofibular ligament. The calcaneofibular ligament, which I don't think I have on this picture, goes from the inferior fibular tip to the calcaneus. And this is a very good ligament to look at on the oblique coronal, that oblique coronal that we were talking about. See if I'll give you an example of that. So here's an example. This they call grade 1 ATFL injury. I don't know if there's edema around there or not, but you probably would just almost always say that's normal. So the grade 1 ATFL injury versus normal for this finding right here. Grade 2 injury is this right here, where the ligament's a little bit abnormal and thickened, and edematous potentially if you looked at fluid sensitive sequences, but not completely disrupted. And here's a nice example of a grade 3 ATFL injury where there's detachment or rupture from its talar attachment. And you see how this is just lax and retracted and wavy. Okay, so we're going to try to look for our ATFL and our PTFL here on axial fluid sensitive images. It's always a little harder when you do it from low to high because I don't do it that way usually. But here it is here. And here's the posterior there. So anterior here and posterior here. Let's see if that looks different on the next image. Yeah, we're already coming out of it. But that's where to look and how it looks. And then once again through the AITFL and PITFL as we come more high. Okay, the calcaneofibular ligament, as I already said, is, if you look adjacent to the peroneal tendons, it's shown as a ligament going from the inferior fibula to the calcaneus. So here's a normal here. Here's a grade 2, which is partially seen. We would have to assume that this continues to attach down here if you go on adjacent images, but this is thick right here. And then a grade 3, I think they're saying here that we just don't see the ligament at all, right there, where we'd expect to see it. So just to emphasize one last time, at UNMC we get that oblique coronal that shows the the calcaneofibular ligament well, but this sequence is not done anywhere. But that will definitely be your go-to sequence to look at it. And if you just use our example here, I don't know how well it is seen in this case, but we'll try. Should be like here, coming down here. Yeah. So that's it right there. Kind of just bracketing it, so I'm not trying to cover it up, but that's the CFL. Usually shown well on that sequence. All right, getting towards the end of the ligaments here, we're going to look at the deltoid ligament. There's two main parts of the deltoid ligament, the superficial and the deep. So I would just think about them separately and evaluate them separately. The deep deltoid is the anterior and posterior tibio-talar ligament. You see those on coronal. They're usually pretty easy to see. This is the posterior. The posterior is the one that just seems more easy to see. You're like, oh yeah, that's the tibio-talar ligament. And then you go more interiorly and you're like, oh, it's kind of hard to see the anterior, but that's just how it is normally. So this is the posterior tibio-talar ligament. And then at the anterior margin of that, there's also the anterior tibio-talar ligament. And that's the normal deep deltoid structures. Now the superficial deltoid is superficial to that. So if that's the deep deltoid, we know that this has to be the superficial deltoid. And that has multiple ligaments which have a little bit of complex anatomy. And at their distal attachments, they variably insert with the spring ligament. So that's a little bit hard anatomy to know, but I think worth learning. But for whatever reason, I got in my mind these three letters: navicular, spring, calcaneal. So NSC. Tibionavicular, tibiospring, tibiocalcaneal. So when I'm looking at the superficial deltoid on axial images, as I'm kind of scrolling down the ankle, I know that somewhere in the front is the tibionavicular, and then behind that is the tibiospring, and then behind that is the tibiocalcaneal, and they all kind of insert on the spring ligament. That's in general how I think about it. So I don't know how easy this is going to see on our images, but let's try. Okay, so you can find this this kind of rounded or curvy ligament that's coming around. So that's the superficial deltoid as it transitions into the spring ligament. And the main one I just usually think about is the tibial spring ligament. So it's the tibial spring ligament inserts into to the plantar calcaneal navicular ligament, or the spring ligament. And even the spring ligament itself has complex anatomy, and which I think is just beyond the scope of this lecture. I mean, I guess if you want to try to remember anything, you'll just know that inserts on the spring ligament. And if you want to know more, it's technically the superior medial portion of the spring ligament. But that's the general anatomy. So I don't know how easy it's going to be see otherwise on this coronal. This is all more area of superficial deltoid, but this is not well, it's just not well seen. It's small. Here it is. This is actually a little better here on this image, right here. So we're seeing the deltoid. I wasn't really paying as much attention to the deep deltoid, but this is the deep deltoid here. And this is the superficial deltoid here. You're in the superficial deltoid because just superficial to that should be kind of your tibialis posterior right here. And you just kind of have to use multiple sequences, planes, and get used to how it looks to get more used to it. So that's one run through the coronal. Hopefully somewhat helpful as a starting point. I love this picture. It's from a rad source, which basically just cements that idea in my head of what I'm trying to see. Tibionavicular in the front, tibiospring in the middle, tibiocalcaneal in the back, and kind of all inserts on the spring ligament right here. So this is one I just stared at for a while until I'm like, okay, this is the superficial deltoid. I think I get it. Here's another look at a normal. So this is the same thing here, where you see this tibial spring ligament here. It's coming down, and it's making its transition as the spring ligament here. So you just see that nice thin structure that comes down and makes this kind of arch support on this talus. Adjacent to that, we have a tibialis posterior, which may or may not be abnormal. Looks a little thick there to me. Okay, and that's the coronal. So this is the axial. Once again, just the color coded the same way: tibionavicular, tibial spring, tibiocalcaneal. One helpful little pearl that I got is, if you're scrolling down on your axial images, I mean the posterior tibial tendon is pretty easy to see. You usually can find that, and you can also usually find the concavity of the neck of the talus right here, which I should be using a different color, so I'll try right here. But if you look between the concavity of that talar neck and the posterior tibial ligament, right between the two is the tibial spring ligament, which is kind of one of the most important parts of that kind of deltoid stabilizing or deltoid ligament structure. Now in this picture, it looks like the tibialis posterior and the between there is kind of more the tibiocalcaneal ligament. It doesn't really matter. I mean, that it's just kind of all the same, ligamentous complex, but that's the superficial deltoid as a general more term of what is right here. See if we can find that on our images here. All right, so this is our tibialis posterior. This is the neck of this is the concavity of our neck here. So we think this is going to kind of be it here somewhere, which I want to erase because we're not going to be able to see anything. So I think this is probably a pretty good look at it here, like that little dark band right there. And there, as it comes up to attach. Okay, that's one run through it, but that's the general rule. And these are often normal. It depends on the history of injury and things like that. But if it just looks abnormal or thick or edematous, deltoid ligament sprain is a general term. Next topic is talar dome. One of the main things to look for here is an osteochondral lesion. If you do see an osteochondral lesion, there's several things to describe: the size of the osteochondral lesion itself, the status of the overlying cartilage, if there's any evidence for subchondral edema or cystic change. One of the most important things is if there's rim fluid signal undermining the lesion, which would indicate instability, if there's any articular surface incongruity, and if there's any associated fracture. And osteochondral lesions of the talar dome is kind of its own topic, but those are just some of the simple concepts I think that are good to start. But you definitely want to look at, especially on your coronal images, and run through the ankle and look at the talar dome and assess for osteochondral lesion. This would also be your opportunity to assess in general for the ankle joint DJD if you see osteophytes and chondral loss and things like that. So this is one run through the ankle to look at our talar dome, which we see here. Looks nice and normal configuration, normal marrow signal, normal cartilage, no concerns. Okay. Next topic is cartilage and bones. So once I've done the ankle joint, I don't want to miss anything else. So look through a general look on the other sequences through the other joints so that you can see in the mid to hind foot. And specifically when I'm doing this, I'm really just I got my fluid sensitive images up and I'm just looking for something bright, edema, something to trigger me to take a closer look. And if you do it this way, you can tend to pick up on things like tarsal coalition, arthritis in the other joints of the mid and hind foot, fractures, and bone lesions. Here's an example on the left of talocalcaneal coalition, also kind of a separate topic, but this is solid osseous coalition of the talocalcaneal joint, which is one of the main, which is one of the two most common types of tarsal coalition in the foot. And I think a main workhorse sequence for this is the coronals, and I'm just looking at all these tarsal bases, cuneiforms, cuboid. Just look at everything to make sure you want to find everything there is to find. And you can do that in all three planes. Sinus tarsi is one of the last structures to look at. This is a normal space between the talus and the calcaneus, which is a fat-containing space. So that's the main finding to make, is that you look at it and make sure you have preserved macroscopic fat. There's several ligamentous retinacular attachments in this region. For example, the cervical ligament, but the main finding is just to look for the loss of the fat and if there's increased T2 signal, because that can be an indication of something called sinus tarsi syndrome, which is a clinical diagnosis, but we want to make that finding if it's there. So that's usually seen on sagittal. I gave you the T1 non-fat sat here just because you can see the fat. You just want to make that finding that there's fat in that space. And that's it. So the end of the presentation here is just all the normal scrollable images. Hopefully this has been a good starting point to be more comfortable with ankle MRI, to know the main anatomy things we're looking for. Use it as a good starting point for reading pattern-based approach, and good luck. Thank you.